Good morning. So I'd like to welcome everyone to a nice, warm, wonderful day here in D.C. and begin with a special thank you to the sponsors who have helped make this event successful. You're probably wondering, why is this guy, John Otterstetter, sitting in front of you when you really want to listen to the panel? And so what I'd like to do is set up the panel in a way with some of the data and statistics that are very relevant to mobility and thinking about healthcare and mobility. First off, let's think about this event. When HIMSS and mHealth Summit joined forces and unified their efforts, the results are very evident. There's 4,000 plus attendees, 50 plus countries represented, and over 300 exhibiting members. Just 2 or 3 years ago, the numbers were a quarter of that. So the emphasis is clear. Now let's think about mobility in the context, first off, of users, and then we'll bridge to healthcare. Smartphones have now passed new PCs, and that was early in January of 2011. More smartphones and mobile devices are being sold than PCs. Morgan Stanley predicts by the end of 2012, there will be more connected mobile devices, approaching 7 billion plus devices. There's 7 billion people on the planet. We're all carrying multiple devices. Think about some of the statistics that are suggesting that by the year 2020, we could hit over 1 trillion mobile devices. So what does this all mean? Think of the traffic behind that. 33% of the internet traffic is relevant to PCs and desktops. The rest is coming from mobile devices. You think about Facebook accounts. 25% of the traffic in the internet is coming from social connection and connectivity. Think about the games that attach to the internet. Prime time, 30% of the internet traffic during the U.S. during prime time is 30% of it is Netflix streaming. Gaming and entertainment. So as you think about mobile computing and healthcare, what are the adjacencies in social and entertainment, and how do those aspects affect healthcare? So what does this really mean? When I think of it in the context of our esteemed panel, and how are we going to lower readmission rates in hospitals and positively influence a patient, the engagement of a patient to the physician? The logical question is what does mobility play with that? How do these devices interconnect? How do they add value to the life of an individual and ease the patient and physician's engagement cycle and drive more productivity and positive outcomes? Pre-event at a physician's office, post-event, and during the procedure. Can mobility have an effect? My suggestion is we'll learn more about that. It's a wonderful morning. I thank you for your time. Thank you for coming to the event, and I look forward to what the panel has to share with us. Thank you.
Thank you, John. Thank you, John, and thanks to all of you for coming out and joining us this morning. I think you'll agree we have a really great panel and some really interesting topics to discuss with you this morning. I want to also thank our diamond sponsor, Accenture, and our gold sponsors, AT&T and Preventus, helps us bring this great content to you. I do have a few housekeeping items. One is that if you requested a vegetarian or a vegan meal, we have Heather is standing over on the side here. Just raise your hand and let her know, and she'll bring you over a card. See one in the back, Heather. So there's more information about our speakers today. You can look at your event programs on the tables, and you'll notice that at almost every table we have USB drives on the chair. If you did not get one, see one of our staff afterwards. Is that me? Good morning, everyone. That'll wake us up. But regardless, the materials will all be available for download on our site. We also have evaluations at each table. We really appreciate your feedback. It helps us develop better programs for you in the future. And so please do take just a moment at the conclusion of the event to give us excellent marks. And lastly, please remember to turn off all of your cell phones and electronics. It can interfere with the sound and get dirty looks from everyone in the room when your phone goes off. Okay, so let's get started. Today we're talking about, did the phone just ring? But today we're talking about remote patient monitoring to reduce readmissions, which of course we know is a huge issue in the healthcare industry. Readmissions penalties have already started to kick in at Fierce Healthcare and Fierce Health IT. We've been writing about the fact that even though hospitals are doing a lot of work to improve quality, they're still getting dinged on those readmissions, and they're still getting penalized for some of the quality issues. So, you know, a lot of people see mHealth as an opportunity to give hospitals and other providers an edge in that. So I'm going to quickly introduce the panel. We won't spend too much time on introductions, so we can get right into the meat of the discussion. I'm Gianna Shaw, by the way. I'm the editor-in-chief of Fierce Health IT and FierceMobileHealthcare.com. Be sure to visit us online. And we also have with us today Dr. Viren Summers. He's a professor of medicine, a consultant in cardiovascular diseases at Mayo Clinic and the Mayo Foundation. Welcome. And we have Dr. Elaine Lebrique. He's the founding director at Johns Hopkins University Global mHealth Initiative. Dr. Alan Snell, welcome, is the Chief Medical Informatics Officer at St. Vincent Health in Indianapolis, right? Mm-hmm. There's a few St. Vincent Healths. And Francis Dare, who's a Senior Executive with Accenture Health Practice, welcome. And Craig Kaiser is Director of Business Development, Emerging Devices at AT&T. Welcome, everyone. Thank you. So I'm going to start with a real broad question, which is about, you know, I know that this conference, we love to talk about technologies and gadgets, and so let's just talk a little bit about what some of the technologies that folks are using. And Dr. Summers, I'd like to start with you. If you could give us a brief description of the Body Guardian program that you've been using.
Thanks very much, Gianna, first for allowing me to be part of such a distinguished panel.
Thank you.
It's really a privilege. And I'm impressed at how many people turned out so early in the morning. I've been working with my colleagues, Charles Bruce, Paul Friedman, Kevin Bennett at Mayo for the last 10 years on developing an unobtrusive, pervasive, effective, and comprehensive remote monitoring solution. And the background to this is essentially we're cardiologists, and we identified significant deficiencies in our ability to deliver high-quality care to our patients, particularly when they left the hospital. And we sought to find a solution to this, and in doing so, we realized that there was a compelling need for a platform for remote monitoring, both in health and in disease. And over the last many years, this has eventually evolved into what is now the Body Guardian technology, which is driven by Preventus, and which we feel will offer new and previously uncharted dimensions in our ability to deliver high-quality care without increasing the quantity.
Now, let's just back up a little bit and tell us, what does it do? What does it do?
The plan is to have multiple iterations, and the device would evolve based on technology available and patient need, with patient need being the primary driver. At this point, the solution consists of a suite of sensors which monitor EKG, high-quality EKG, activity, breathing, and integrates all of these measurements into a continuous stream of data, and allowing us to visualize patient activity, patient physiology from a distance.
Right. And you had mentioned, so for example, you can tell We'll talk a little bit more about this in greater detail later, but so for example, you can tell when a patient is at home whether they're moving around or perhaps they've experienced a fall or...
Correct,
Yeah.
correct. We can tell based on body position and EKG and actigraphy exactly what the patient is doing, and if the cardiovascular status of the patient is appropriate for the patient's level of activity, which is a very important concept in remote monitoring, integration of physiological signals.
And we should say that although you're using the Body Guardian technology, this isn't, it's not the only device that we can use to get this done. There are other tactics as well.
Right, absolutely. So the key, I think the key differentiator is that this is not a device looking for an application. What we have is a set of problems, or we could see them as opportunities, where we can improve the quality of healthcare, decrease the cost, and the Body Guardian is one avenue where this can be done, but it is clearly not the only solution.
Yeah.
Yes.
There's a lot going on. In fact, does anyone else want to jump in and just sort of talk about some of the other remote monitoring technologies that are out there or perhaps that are emerging?
So,
Dr. Labrie?
again, thank you, Gina, for having us on this panel and such a fantastic audience so early in the morning. It's great to be here. I think there are two dimensions to the problem set of remote monitoring. One can be steeped in technology and sensor-based, let's say, enhancements to our ability to follow patients when they return to their home. But there's also the enhancement of the patients themselves and thinking about self-efficacy and how do we extend the, the reach of care beyond the facility into the patient's home. Sometimes we like to say that the most powerful use of a phone is often as a phone. And so thinking about strategies which engage the care team with the patient beyond the boundaries of that immediate care experience to the home can eventually have long-term cost reductions that go beyond even the definite advantages of having monitoring systems. But I think the other aspect of this is thinking about how we can use what our colleague said earlier, the social networks that individuals are part of, to expand the core care team that we traditionally define as the provider and the patient to family members, to members of the immediate ecosystem with that patient interacts with. So there are technologies, but there are also human enhancement strategies, which I think are exciting in this new age that we find ourselves in.
Yeah.
Yeah, and I would add to that, in fact, it's not one technology, right? We have the power of integrated sensors, network biometric devices, web apps, and smartphones, and bringing those capabilities together to do exactly what was just mentioned, where my biometric device or my health status based on sensors or those network biometric devices is then sent to a server, a secure server, where then there's web access and smartphone capability so that I can know what my status is, the people in my extended care realm, including my friends or my families, my clinicians at my choice, can see what my status is. And I think especially to our topic of avoiding readmissions, much of remote monitoring is rooted historically in chronic conditions and a care management model over time. But even episodically ill people who discharge home for some period of time can take advantage of technologies for that window when we want to see those readmissions reduced.
Yeah. It's interesting. This is definitely a theme that seems to be popping up at least over the past year, this concept of the ecosystem of care. And so, Craig, I'd like to ask you, how is wireless dovetailing and helping enable that ecosystem of care and bringing in so many disparate pieces of technology and data and so on?
Sure, and you used the key word there, enable, and that's primarily what we are. We built out this network, and the network is there to allow for all these great data transmissions and voice transmissions to occur. There's certainly a lot to be done still. You know, the coverage is fairly prevalent here, but there's still going to be gaps where you simply can't get the coverage you need to support some of these remote offers. But at the same time, I think you know, there's great potential for that to change over the near future. And cost, too, I think, And when you're talking about a blood pressure reading or a glucose meter reading being sent over our network, fairly easy, little bits of data. But when you start moving that forward to video transmissions and really having those consults on a regular basis, there's still a challenge there with wireless in terms of just the amount of data being used, maximizing our network and keeping the costs down so that we can facilitate these great types of solutions.
Yeah. Great, thank you.
You're welcome.
So I'd like to move in now to some specific examples of how remote monitoring is reducing readmissions in some very real ways. Dr. Snell will tell us now. I know that you had a session yesterday where you went over a lot of information about the pilot program you did. So can you just give us a thumbnail sketch to share with the audience about that pilot you did and the success you had with it?
Sure, Jen, thank you. Yes, I know some of you were in this room yesterday afternoon when we did the session, so I won't repeat all of the detail on that, and if you want more detail, I'll stick around after the program is over and give you that if you wish. We are in Indianapolis, St. Vincent Health is part of Ascension, the larger Ascension Health organization, and we're also a part owner of Indiana Health Information Exchange, and I sit on their board. And Indiana Health Information Exchange was the winner of the one of the 17 Beacon Grant Awards. So as one component of that Beacon Grant Award, we wanted to study readmissions and how we could use mobile technologies and patient education delivered into the home to reduce readmissions. So it's been a 2-year study. It ends this month. And so far, we have 2 cohorts of patients totaling about 350 patients. So 200 patients were randomized coming out of the hospital with a discharge diagnosis of CHF, heart failure, or COPD, lung disease. So they had to have those 2 diagnoses. And then we randomized them. So they were not referred by physicians. Well, they were not referred by physicians. We did this and had an IRB and a consent form. So the patient nor the discharge nurse nor the physician knew whether they would be in the program. So over 200 patients. Results to date so far on that is 5% readmission rate in the intervention group, 20% readmission rate 30-day in the control group, 75% reduction. And the 20% mirrors the national average for those 2 diagnoses. So we were just amazed at the dramatic drop in the readmission, and I can go into later why that is. But in addition to the 200 patients, we had 150 patients, because we had excess capacity in our devices and also nursing time, that we actively sought the sickest patients we could find, whether they're in the hospital or just had a history of frequent admissions, readmissions, ER visits. We went to different agencies, home health, we went to practices, and we said, give us your sickest patients. And then we developed baselines on what their previous utilization was, and now are comparing that when we have the data available. And in those patients, 150 patients, we are finding dramatic, very dramatic drops in utilization of the hospital and emergency room, because it's all about early intervention. So the key components is not only monitoring the vitals, which we do, blood pressure and weight daily and pulse oximeter when indicated, but it's really the education that we provide through the devices for the patients, even in sometimes those short 30-day windows, that we're actually measuring the impact that the education has on the population, because that has a longer shelf life. And then we're also now developing protocols to wean, evidence-based protocols, to wean the patients from the higher cost, higher technology, down to a mid or lower technology realm. And just like we have evidence-based weaning protocols for patients on ventilators, we now want to develop those protocols and deploy that across the population base. So our effort now is really not just focused on readmission going forward. We really want to focus on keeping patients out of the hospital, period, because we see every hospitalization as a potential failure.
Great, thank you. And there's a fabulous example of concrete results and evidence that this is working. I know we want to go into what else we need to do to ensure that that's happening. Does anyone else have any examples that they wanted to share of programs that are working to reduce readmissions. Seem to remember.
So I can give you an example from work that was done at Johns Hopkins. Martin McRae and his colleagues found that 23% of colorectal surgery patients discharged return within 90 days, resulting in about a $9,000 cost to privately insured individuals and an annual cost of $300 million a year. It's a huge. So even reductions in 5% and 75% is phenomenal, but would have a major impact on our bottom line here. But when you look at the risk factors of what tends to be the profile of patients who are subject to readmission, you're looking at severity of illness, you're looking at incision site infections, individuals who have complex follow-ups, colostomies, ileostomies, where the regimen of care in the home is fairly complex. And so the degree of self-efficacy that you need those patients to have once they return to the home is fairly high. So there are systems that we've used, for example, with remote patient training, patient education, videos on demand to allow patients to ask very straightforward questions about their postoperative care that they can have streamed to their handheld devices on demand to prevent, say, ER visits, to answer simple questions that could have been managed through a phone call, through a video conference call, or even through patients looking up their own data. But it's also about coordinating care at the time of discharge. Being able to provide the patient with a care plan that they can then refer to with their smartphone or ubiquitous device that follows them into the home. One of the biggest domains, both in domestic mHealth and in global mHealth, where we know that there's evidence for impact is in the space of adherence. So very often we release patients with fairly complex regimens of drugs that they have to adhere to. And the one domain that we're really seeing growing evidence is that when this device in your pocket reminds you to take your drugs on time, in the right order, and persists through to follow up when you actually miss a dose, or that connects your care provider to you when a specific regimen is not being followed, I think that has tremendous potential to actually impact on the rates of readmissions. So it's those kinds of exciting, I think our colleague might be able to share some more about glow caps and that kind of adherence technologies. But even, I just pulled this off my belt, I'm wearing a Fitbit, a $90 piece of technology that monitors in a 3-axis accelerometry my movements on a daily basis. The next version of this, which just came out a few months ago, actually has Bluetooth connectivity. So it can constantly in real time share information with my phone just to get a simple metric as whether or not I'm moving X amount of steps during a given hour or during a given period of time during the day. So it really lowers the bar for what constitutes monitoring at the home context with very simple technologies.
I'll be vendor neutral, but I'm also wearing one of those devices. I won't tell you which vendor uses it.
So this is my personal, Johns Hopkins doesn't certify these devices. So.
No product endorsements here. You know, Francis, when we were having the planning call for this event, of course, we did spend some time debating, okay, what is mHealth and what counts as remote monitoring and does text messaging count? But I think that that's a conversation that's happening all over the place at this conference and in general, right? But I know that you had some thoughts about, you know, what kind of things fit into this category. Did you want to quickly go into some of those? Or?
Yeah, so there's such a huge range of, as I said before, technologies that we can bring together to address the core needs. My background is in health administration. I started out in hospitals a really long time ago. So I tend to frame this as what are the new clinical models along with the disruptive technologies. What are the disruptive approaches to engaging patients, which is really what this is all about. And engaging patients with their extended ecosystem of carers, however they want to define that. So if we think about a couple of examples, I mentioned a minute ago the historical roots of what we've come to call remote monitoring. Go back to the earlier mid-90s with the first disruptive technology. It wasn't mobile, but solutions like the Health Buddy device. And that had a dramatic impact. It was the first wave of reducing ER utilization and reducing inpatient admissions. But the other disruptive dimension of that we don't talk about as much is that it doubled the capacity of the Veteran Health Administration's care managers. They went from about managing 80 patients at a time to having a panel of about 160 or even 200 patients. So it was a huge capacity thing as well for the workforce. We're kind of still in that place today when we are still focused on diabetes and congestive heart failure and COPD and that approach that's care manager anchored. But the new disruptive approaches to engaging those patients can include things like I have a cellular connected blood glucose meter, glucometer, and I do my test, and that's sent over automatically over a cell network to a secure server, and through a web portal, then I get, well, first of all, I get immediate feedback that says, great, thanks for taking your reading, or if I have clinical protocols customized for me, built into that system, I get additional feedback specific to what the reading might be. And I as well can say, I want my physician in my patient-centered medical home practice to have access to this, but also my friend who has diabetes, because we sort of support each other in this. Or my, parents maybe, or if I'm a grown child of an adult parent, I want to be part of that support to that family member. So we get beyond having that care manager as the anchor, but other people are supporting this. And if I'm the physician in the patient-centered medical home practice, I don't want to have to be constantly, or somebody in my practice constantly monitoring at a workstation what's happening. But I get those messages that are alerts that say, okay, something's going on with one of your patients. So then we can really focus and intervene. So it's a combination of text messages back or secure emails that can go back and forth between that connected system of folks, web applications that manage all of this information, and customized learning as well. So when I think about what are the characteristics of the disruptive or new approaches to that kind of care management process, they're scalable, right? So we can get beyond hundreds of patients being managed into the thousands, right? 28 million Americans have diabetes. We can't hire 140,000 care managers to support them, right? So we need things that are scalable. We need things that are flexible enough to be customized for individual patients. They need to engage that larger social network of carers and supporters. And we really need to be able to look at additional conditions, not just those core chronic diseases, but some of the other things that are high expense items for all of us in the healthcare world.
Dr. Labrie?
So I think this point you bring up about the downstream team that's needed to support these remote monitoring applications is critical. We're currently, colleagues Larry Cheskin and others at Johns Hopkins are engaged in a randomized controlled trial to test the efficacy of tailored text messaging to support clients who are struggling with diabetes and weight management. And one of the systems that they've developed is actually an automated server-based strategy where patients are requested to submit specific pieces of information on a daily or weekly basis about their weight, about their glucose reading, and based on prior information, the server automatically customizes a response to that patient's submitting a piece of data. So it says, good morning, John, could you please send me your weight today? Now, in the future, we can expect that to be automated as devices are connected in the home. But for now, that kind of a strategy is followed by a response saying, oh, you've now dropped a pound from where you were last week. Congratulations. Or, I know this is hard. Your weight has gone up a little bit, but don't give up. And that customization in our early qualitative feedback has really been perceived by the end user as something very valuable. Even though they know fully well that there's not an individual on the other side of that phone responding to them, that perception of a tailored text message is found to be very valuable. So even some of that support can be automated, can be electronic, and have a similar value proposition to the end user that we wouldn't have expected. We would have thought there's transparency. They know there's a server that's not going to have much of an impact. But we've had patients come back to us and say, I feel like there's someone watching over me. I feel like there's a guardian angel or a doctor in my pocket. And that kind of affirmation that this personalization can be automated and can be effective.
And of course, although we're not saying it explicitly necessarily at this moment, of course that comes back to readmissions, because when you do a better job of monitoring patients in all of these different ways when they're not in the hospital, the chances are better that you won't bring them, that they won't come back in.
So I want to touch on two things that Alan and our other colleagues brought up. The first is education of the patient and the patient's caregivers in the home. I think it's very important to ensure efficacy of the monitoring technology. The second is the concept that no matter how disruptive a technology in medicine, there really is a very high priority on demonstrating that it makes a difference. Outcome measures are key. I think, Alan, your trial has been very important in helping set the stage for some of that. At Mayo, we've been fortunate in that the NIH has given us about $3.5 million, and Mayo's put in another $3 million to actually do a randomized trial of using the Body Guardian, although again, it could be any equivalent technology, of using the Body Guardian to determine if we actually do make a difference to readmissions in patients with heart failure. And that really is the acid test. And we, no matter how, again, how wonderful and fascinating the technology, at the end of the day, the imperative is to prove that it either improves the quality or decreases the quantity and cost of care.
Yeah. I know we wanted to talk a little bit about standardized trials and outcomes, but I just want to, if we have time, we'll come back to that at the end, because I feel like there's a really big piece of this that we need to get to, which is, holy cow, there's a lot of data coming out of some of these devices, right? And what do providers do with this data? We talked about back-end issues and how to integrate those multiple streams of data. So I know both Dr. LaBrique and Dr. Summers have something to say about this. Who wants to start? They're both going to start.
So the question is, where does data go and what happens to it? And this speaks to another concept that underlies remote monitoring, that it is one of the most multi-specialty activities that I have ever encountered. We're cardiologists, we work with engineers, we work with endocrinologists, we work with behavioral scientists to develop the ergonomics of the device. We have to work with informatics specialists to actually decide how to process and deal with the large volume of data that's coming. And so that speaks to, again, the back end. We have to be careful of several things. We have to be careful not to excessively burden the patient with interactive technology, and we have to be careful not to excessively burden the physician or healthcare provider with too much information. So along the way, we have to provide effective filters to only give the physician, the nurse, the caregiver, the information that is directly and most compellingly relevant to the patient's condition. And this is why we have to bear in mind several important aspects of monitoring. That is, the monitoring of a patient has to be customized to the individual and to the disease and to the objective of remote monitoring. We have to have a very good idea of why we're monitoring this patient. Is it to look for arrhythmias? Is it to prevent readmissions? Is it to detect heart failure? Because the construct of what we want from the data will change. And so that has to be an important consideration. The other consideration is who sees the data. And in trying to approach this problem at Mayo, what we've been working on is a set of physiologic monitoring technicians. So we know many of you are familiar with telemetry monitors, with Holter monitors, where you have a group of technologists who sit at a distant spot and monitor people whose EKG is providing remote information. Well, what we want is physiologic monitors, not cardiac monitors, people who can monitor activity, who can monitor breathing, who can monitor the EKG, who can monitor brain waves and muscle tone to tell if you're asleep or awake, who can monitor posture to tell if you fell or whether you're lying down, and what the patient's condition is. So all of these things cannot be processed by an EKG technologist. People have to be trained to understand, assimilate, process, and very importantly, filter the information that they're getting. And so what we're trying to work on, what we're actually gone quite far on, is a bank of physiologic monitoring technologists who will provide an important filter for the volume of data coming from the patient before it gets to the physician. So at the end of the day, the physician gets only that data that is compellingly relevant to the patient's condition.
Very, very eloquently put. I think the first point you made is critical. The burden to the patient is something that is paramount in this equation. Thinking about how do we make these systems as non-invasive and unobtrusive as possible to the patient as they're being monitored. The more input, the more active participation you need, the greater you risk having that level of engagement fall off over time. But it's also a problem of signal-to-noise detection. One of the challenges in this space is that physiologic data is inherently messy. More data is not necessarily better data, and we've all heard this mantra said before in many places. But the challenge is one of data management, of number crunching and figuring out for each individual what constitutes a normal baseline, what constitutes normal evidence of activity for that individual that can be extrapolated to a population and that makes sense for that specific individual. So I think the issue you bring up of integrating multiple streams of data is one that technologically we're now increasingly capable of doing that we may not have been 5 or 10 years ago, to integrate data from breathing, respiration, from heart rate, from EKG readouts in real time, such that false positives can be reduced. What you don't want to do is increase the rate of concern because of these kinds of physiologic remote monitorings that aren't related to actual outcomes or complications. I think the other technology that's come to bear right now is neural network analyses and artificial intelligence applications, where you can potentially transfer some of the load of processing onto sophisticated computing systems away from the technologist having to screen every single patient, at least as the first pass. So I think you want to be extremely sensitive and not very specific at that first layer of identification of risk, and then perhaps have a human being step in and really make that last determination of whether an action needs to be taken or not.
Well, that's a really nice segue into going back to Dr. Snell, who had alluded that there is some more news to come about the pilot program you've been doing. Can you tell us a little bit about how you plan to use data analytics in the next phases of this program, and what kind of work you'll be doing next?
So as our Beacon grant-supported project comes to an end this month, and we'll be doing all the publications and final analysis in the first quarter next year, we've already made plans to move forward, expand the program, and scale up very dramatically. So St. Vincent Health and its parent organization, Ascension, have agreed in principle to actually create a joint venture company, yet to be determined exact structure. But part of that will be then not only how do we approach our St. Vincent patients, but how do we begin to scale up across Ascension in a national strategy? And then how can we also provide a lot of these services for non-St. Vincent, non-Ascension sites? I'm being approached already, actually frequently now, by payers, multi-specialty practices, and even other hospitals. They're saying, you know we have to do something. We know the technology. We can go out and buy the technology. The piece that we're missing is the nurse monitoring capability and that secret sauce that you've been able to define. So, they can buy technology, but it's how do you apply the technology? So going forward, we're looking at at least three different strategies. One is in addition to the technology, which, by the way, will move to a newer platform, more flexible, certainly more efficient software platform, and the end device will be agnostic, and it'll all be basically tablets. But what we really want to do is begin to focus now on how to deliver the patient education and engagement strategies. We think that is definitely part of the secret sauce. It's not so much about the technology, the physiologic monitoring, that's important, but the shelf life, the longer shelf life, once you wean patients off the monitoring, is did you, while you had them connected, did you take that opportunity to really educate them and their family and their social circles and their support on how to best take care of that, okay, of their particular condition or multiple conditions. The second, of course, is we really want to do a good assessment at the beginning and use 3 areas. One is what's their historical record been for utilization, what's their current acuity level, their current conditions, and then predictive analytics. Where do we think the patient's going to go in the next 6 months, 12 months? What kind of issues are they going to have? So again, the power of all of that. And then that puts us into a customized care plan for each individual patient. And that customized care plan, I can't emphasize enough the importance of that. My physician colleagues are really grumbling now. Accountable care means that I'm on the hook, right? And I can tell patients that they need colonoscopies, and I can ask patients to monitor their blood sugars. But if they don't, where's their accountability? What's the accountability on the patient side? So I hear this constantly. So I think we can solve that through, or at least improve it through a lot of the technology resources that we've heard about today, because to me, a customized care plan is really a record of how adherent or compliant that patient can be. So it's not only receiving information, physiologic information, for example, as we've been talking about, but it's pushing information to them through the mobile connectivity and then asking them to respond. In many years of my practice, I'd ask my diabetic patients, bring me your blood sugars. Well, they'd bring me the ones they wanted me to see. Okay? And then when I checked their glycosylated hemoglobin, it didn't match, right? And I'm sure many of you have been in that situation. So it's really moving, and I don't like the word compliance, I like adherence more. So that's data. And we're finding that that particular part of the data stream is just as important. So we think that those are the main components. Now, one last thing is we're very blessed in Indiana. We have 5 health information exchanges. So about 90+% of all 6 million residents are in one of those exchanges. Early next year, those exchanges will be connected to each other. That's a very powerful mechanism for us now to harness that, and we want to pull that, all that information too, into our program. So we really have the complete picture of what this patient's clinical condition is, but maybe even more importantly, what's been their course, what's got them to this position, and maybe we can correct some of that, and then predictive analytics and other tools to say, where can we avoid some of the pitfalls that we know with 90% certainty that they're going to run into if we don't intervene. So that's where we're going with the program next year and the following years. And we anticipate we'll be monitoring several thousand patients in another year or two.
That's great. You know, we're definitely going to leave some time for the audience to ask questions, so you can start thinking about that now. I think we want to get into that fairly quickly, so I'll just ask one more question, which is, how can the data help, and it's a little counterintuitive, but how can the data and algorithms help us understand who does not need remote monitoring and reduce some of the costs of care in that way? I can't remember who was talking about that.
Okay.
Do you want to?
So you know, the volume of data that we're getting now is unprecedented. We've never encountered this amount of information before. And Elaine brought up the issue of neural networks as a buffer for the technologists. Certainly, we're not at the point yet where neural networks need to be informed by your understanding of the data we haven't reached the point yet where we can develop those neural networks. We still have to learn about the data, how they interact, before we can start informing neural networks if we're happy that it's going to be a reliable buffer between technologists' workload. But some of the things we have learned is that it's how you look at the data. For example, if you have somebody with heart failure and he is walking, your technology indicates that he's walking up a slope and his heart rate's 100 and his breathing's at 20. Well, that makes sense. You know, he's got heart failure, he's compromised, he's exercising, his heart rate's going to be fast and his breathing is going to be faster. But if that person is lying supine and he's got a heart rate of 120 and he's breathing at 24 breaths per minute, then you know there's something wrong. So it's really not just looking at single points of data and trying to understand them, but it's how the data speak to each other. That's really the key in understanding what's going on with the patient and whether and when an intervention is indicated. The other thing is that you know, I want to just touch on something else that we talked briefly on. That is disruptive technology. We can bring in disruptive technology to decrease cost, and we can bring it to improve outcomes. One of the places where cost is really a huge barrier to care is in sleep. And sleep studies cost about $2,500 to $3,000 just for one night. And that's a huge burden. That's why many people who need sleep studies just don't get them. And so as part of the remote monitoring initiative, we've been working with Preventice on something called Sleep Sound, where we are able to listen to somebody sleep at night, process the snoring, and use, those of you who have spouses who have sleep apnea will find resonance in the fact that we use earthquake detection technology to process the snoring to determine if this is healthy snoring or is it apneic snoring. And so that's one example where we can look at 1,000 people, find maybe the 200 who actually need a sleep study, and therefore decrease cost of care. So the spectrum of remote monitoring is actually so broad, and the objectives need to be not just improving outcome, but also just in and of itself decreasing cost.
It's a great example. Yeah, Francis.
Quick example to the point that remote monitoring can be really broad and maybe expand our view around this. Alzheimer's patients. There are over 5 million Americans that suffer from Alzheimer's disease, and that's a disease that particularly also really impacts family caregivers as well. So the Alzheimer's Association back in 2009 said, we want to support those families by being able to remotely monitor people with Alzheimer's disease for something as it could be perceived as basic, but also important as, are they in their safe zone? They call it their comfort zone program. And so with cellular devices in their pocket or tracking systems in cars, if the Alzheimer's patient still drives, the family can decide what's that safe zone, and maybe that's safe during the day and it's different at night. But with those tracking technologies, along with a web app, and in the early days, a call center service that would track those patients at whatever frequency the family needed, and would immediately alert the family if the patient was going out of that safe zone. And more recently, they've added the ability for family members just to securely log on to the website, and they can see where the family member is on a continuous basis throughout the day. So it's less data intensive, it's less about the acuity of the disease state, but it is highly impactful because the cost of treating Alzheimer's patients on an annual basis is around $200 billion. And the additional cost for those caregivers approaches $9 billion. So even just lowering the stress for those family care providers can reduce their own healthcare utilization and admissions or readmissions to facilities.
This is great. We're really close to running out of time. So I want to make sure, we had so much to cover, let's face it. It's a great topic, and you guys have been great. If anybody has any questions, we have runners in the audience with microphones. Could you just raise your hand? I see a few. There's one in the back and one over to the right.
Hi. Sometimes simpler is really very effective. I'm with a company that does telemonitoring. We've got all the gadgets you'd like. But one of the most effective programs was done by Geisinger, in which they just used IVR once a week for patients who'd been discharged who were seen at high risk. And it was to identify gaps in care. Did you get a prescription? Did you fill it? Do you have a follow-up appointment? Are you going to make it? Do you need help getting there? And just doing that with case manager follow-up reduced the risk of 30-day readmission by 44%. So it was a very simple, inexpensive solution that was quite effective.
Great point.
Comment. I think we have to be smart in how we assess the patient, as I mentioned earlier. There needs to be, like we do health risk assessment, we also need to be able to assess and assign the level of monitoring. We found, for example, going forward, it is not cost effective to use all the technology we're using now and have in our clinical trial for every patient, particularly those, for example, with the acute MI, pneumonia, CHF, coming out for which there will be no reimbursement moving forward with, from CMS for that 30-day readmission. So, but they don't all need video conferencing. So we're going to use IVR, and many of those lower acuity patients, you don't need all the sophisticated technology. So being able to do that assessment at any given point in time, and then periodically during the course of their treatment is important, because we need to find evidence-based protocols to wean them from higher technology to middle technology to lower technology, or POTS, just plain old telephone stuff, right? And I think we need to use all of those, but we need to do it in an evidence-based fashion.
I think the question actually illustrates how problems in delivering care can be changed to opportunities to improve care. That's a classic example of that.
But I think that the learning opportunity, I think this is something that's critical we talk a lot about provider-side solution generation and technologies that are being built. I think you brought this up earlier, technologies that potentially are built looking for a solution. And that's really not where we want to be going as a field. I think learning from patients, using the data to understand what are the risk factors as our evidence base, our database grows in terms of refinement, to be able to get new insights into who are the patients at greatest risk. I think that's a real learning opportunity that we should not miss going forward, to take this data and integrate lessons from that, so we refine our characteristics of who is at greatest risk and how can we prevent readmissions in those cadres.
Right. We have about 5 minutes left. I know there was a question toward the front of the room. There we go. We'll see.
Well, we're a startup in Oregon. I'm wondering if you have any experience with video, real-time video, along with all of the monitoring systems that you talked about, because we're building something like that. I'm wondering if you have any evidence or experience behind video integrated with these devices.
That's what we're currently using, video conferencing, and it works very well. You mentioned coverage, and we in our state, of course, we have 3 carriers, and we've tried to measure the signal level when we go out into a patient's home and install the video conference, the video devices, so they can video conference with the nurse in the call center. And we only had 1 out of the, like I said, 350 patients so far. There's really only 1 in a very remote rural area that we couldn't do adequate video conferencing. We could still do the monitoring. It was just not a good experience with the video conferencing. And that's predominantly 3G. What I love about the mobile wireless is it's ubiquitous. So many of these patients' homes, there's not even a computer. There's no high-speed internet in many of these older patients that we serve. But 3G is everywhere. So they don't even know. And they don't even know that it's a computer. You know, we just put the device in and say, turn it on, and here's how you touch the screen. So it works everywhere for the most part.
That's great. Questions? Here we go.
The elderly are at a disproportionate risk for readmission, and oftentimes their travel home involves either a rehab center or home health care. How do you see with those organizations so you're not duplicating efforts on mobile devices and mobile health?
It's a great question. Who wants to take that?
Well, again, we're currently partnering with 7 home health agencies, and they have found that it very much enhances their service level, because if you are in more constant, and I won't say every day, but at least several times weekly connectivity with the patient, it helps them plan their visits more efficiently, and it's the early intervention is the key. One of the problems with home health agencies, the way they're designed and the way they're reimbursed for their services now is, it has to be periodic and so many visits and et cetera. But this is where you provide more data so that they can arrange their schedules to meet the patient's needs. So I think it will enhance the home health services, and it will change the way that we do home health.
I'd add a dimension to that, which is that's all about transitions of care, and especially on the rehab side, it's multidisciplinary team-based care. So to the extent that we can also enable easy care, team care, giver interactions. So they don't, in my day when I was at a physical rehab hospital, we got everybody in a conference room to talk through the patient's case. Yeah. But now we've got collaboration technologies that enable that and make it much easier, much more quickly, and the data is available. Everybody can see what's going on with the patient. So it's those transitions and thinking about multidisciplinary care that I think makes a difference as well.
Go ahead.
So two very quick points from your question. First is, as Elaine pointed out, identifying the highest risk group identifies the group also at greatest benefit for remote monitoring, and that's where we get the biggest bang for our buck, because at the end of the day, it's economies of scale that are key. And we want to, in the final analysis, be able to provide remote monitoring at $1 a day. That may seem ludicrous, but I think with advances in technology, I think we will actually get there one day. So the first thing is the high-risk group, the elderly. There, I think we can make a huge impact. The second is the ergonomics, and I cannot emphasize how important that is, because the elderly provide a very special set of needs, and the ergonomics of an older, sometimes confused person are very different from the young 25-year-old who's using the device, the generic device, to monitor his running distance and running time. So this is where the behavioral psychologists play a key role, and we found them to be extraordinarily helpful at Mayo in providing guidance as to how to create the user interface, how to create a device that actually an older person can use without getting confused, angry, and upset.
Yeah. And I think that speaks to the point that these problem sets are really multidisciplinary in nature. It's critical to expand ourselves beyond the traditional team of problem solving in this space that we're used to dealing with. It involves working with computer scientists, folks who are specialized in human-computer interface. There's a whole conferences of this magnitude around that very problem set, how to engage groups in society that aren't traditionally engaged with technology, such as the elderly or other segments. So it's critical to have that multidisciplinary lens. But I think we're also seeing new technologies and new potential strategies. For example, using indirect proxies of cognitive function, I think is one exciting area that's soon to be on the horizon, where you can look at indirect uses of technology. The speed at which individuals push buttons on a simple smartphone game, for example, could potentially reflect cognitive decline on a daily basis. Sorry.
That's okay. We're getting the stop. Time's up.
But even
we're no longer at 5 minutes, 3 minutes, 1 minute. We're at stop.
Sub-zero. But I'll just finish by saying even monitoring the integrity of voice is something that our computer scientists are working on right now, looking at slight signals in voice variation and voice intensity that can be benchmarked from day to day to reflect progression downwards of a patient. So there are things that are really exciting on the horizon.
Thank you. Well, I want to thank all of you for coming out this morning. We want to make sure that we get you on our way. I just want to take one more plea to ask you that you take a moment to fill out those event evaluations on your table. Much, much appreciated. And thanks so much to our wonderful panel this morning. Have a great day, everyone.